Good to go?
Good to go.
All right. Thank you all for coming. I'm excited to be the first one to go for this. So, today we're talking about a clinical trial design that's called a SMART. I'm not going to be presenting too much of like my own research or results from my own research, but more generally about this kind of design, how it's been used in other health behavior research, and then some modifications that I think could be relevant to health behavior research as well. Okay, so getting started. So dynamic treatment regimens, so DTRs. No. No, I'm not playing music actually.
Sweet.
Here we go. Okay. Okay, so DTRs. So DTRs are sequences of treatments and then the decision rules that go along with those treatments. So as an example, start with treatment X. If A, some event A happens, then stay with X. If not, switch to treatment Y. And we usually denote this with a DTR triplet. So this would be like X, that's our first treatment. X is our second treatment if the condition is met. And then Y is our second treatment if the condition is not met. So a more concrete example could be in current smokers who wish to quit, start with motivational therapy and weekly encouragement check-ins. If abstinence is achieved, then continue therapy. If not, add nicotine replacement therapy. And so this condition for deciding if you're going to switch to the next treatment or what the next treatment is, that's called our tailoring variable. So dynamic treatment regimens are sequences of those treatments, the DTR triplet, and then our tailoring variable as well. So a little bit about randomized clinical trials. I think most people here are pretty familiar with why we use randomized clinical trials, but you never know who is in the audience. So randomized trials are considered the gold standard for getting unbiased treatment effect estimates. Usually when you're doing an observational study, there are a lot of outside factors that you can't really account for in your data set that could be influencing treatment decisions or influencing the outcome or both. And that can lead to bias when you're trying to actually get those estimates of your treatment effects. So as an example, if patients who tend to be healthier at the baseline tend to receive behavioral therapy prior to a medical intervention, and we just naively compare the outcomes among these populations, then we might say that behavioral therapy looks better just because of how everybody looked at baseline. They were already healthier. So here's another diagram that could potentially lead to bias. So if age is a factor in receiving treatment and age puts you at additional risk for this outcome, then we can't really get a good estimate of that treatment effect. Because I'm a statistician, there are some slides with some statistical methods that I snuck in here. So there are methods to account for this type of bias that can occur, so confounding, but there are usually really strict assumptions that have to be met in order for those methods to be valid. So we can use propensity score weighting, if you're familiar with that. You estimate the probability of receiving that treatment, but that requires that you're actually able to accurately estimate that probability, which is so unlikely because clinicians and people who are making treatment decisions don't often document every little factor that went into making that treatment decision. And without all of that data, we aren't able to accurately estimate the probability of them receiving that treatment. So because of that, in an ideal world, in an ideal world, we would just use a lot of randomized clinical trials rather than sequential data. That's not always possible. That's often not possible. Okay, so SMARTs are randomized trials designed to compare multiple dynamic treatment regimens. So this is a clinical trial designed to test different sequences of those treatments. This was first proposed by Susan Murphy in 2005, and the goal of SMARTs is to identify a DTR that optimizes some final outcome. So this is an example of what a SMART could look like. So patients are randomized to a first treatment. Then we gather some intermediate response or non-response. This is our tailoring variable essentially, is response or non-response. And then that dictates the secondary treatment. So for patients who respond to treatment A, they stay on treatment A. If they don't respond to treatment A, then they are re-randomized to either adding A or adding B to treatment A or switching to treatment C. So the DTR triplets are denoted over here. So this one would correspond to A plus B, A, C, because we have responders going to A, non-responders going to A plus B here. So that's how that triplet is formed. And then likewise, you could start with treatment B, responders stay on B, non-responders you either add A or switch to C. So this SMART has 4 embedded DTRs that we're comparing in it. A plus B, A, C, B, A plus B, and B, C. But this can have a lot of variations. You could have 3 treatments or multiple treatments that you start with. You could randomize responders and non-responders. So there's a lot of different options for the general framework of a SMART. It's all based on what actual sequences of treatments that you're interested in studying.
Holly, can I ask you a quick?
Are
the questions at the back end then? So does that mean you end up with 6 groups, or is some variation within a single group? Do you know what I mean? Is it treated as like 6 unique?
You treat them as 4 actually. So you compare them based on what DTR people actually end up in. I think that's actually in my next slide.
So you wouldn't be comparing them to A. Like A and B by themselves are no longer.
That would not be that you could test that. You could look at that. But the idea of the whole SMART would be to come up with the DTR that optimizes benefits some final outcome rather than looking at just the first stage treatment.
So is the assumption that the response will not be effective and therefore they are going to the next? And that's why, I guess I understand what you're saying too, because I'm thinking of the condition of A response, it's working, and so they're still group A.
Yes.
So that would not be considered a different group.
No, so that would be like, so if you're thinking about looking at people who stay on A as its own group, and then people who don't respond to A and then go to like A plus B, and then comparing those. Yeah, you can do that comparison as well. You can get lots of interesting comparisons.
It's probably
with
a lot of
this.
iteration.
Okay.
Yeah.
Will you be speaking to, like, at the first randomization stage, the why you would do it this way versus like having 4 groups that are A, B, A plus B, and C, or something like that?
No, I don't have anything about that in here. This is so the design of the SMART is really based on what sequences of treatments you're interested in. So if you are curious about, like, what if we just start with A and B right off the bat, then you would want to include that as a first stage treatment. Because with how I have it set up right here, you wouldn't be able to look at that. You would be able to compare like initial response rates between A and B though.
But it's conditioned on their response, which is what makes it a SMART. Is that what you're?
Yeah.
Right, interesting.
The SMART is, I think the technical definition requires that you have the multiple randomization time points and then the sequences of treatments.
Yes. So I'm just curious, like, what if it's not the response, but it's like the environment that someone's in at the time that makes them not respond to the treatment? And so like how, like, cause there's not like your textbook control group, if I'm understanding this correctly. So you don't ever compare to someone who gets nothing. Is that right?
You could have one of your initial stages be nothing, like you could have a control group here.
Yeah.
And then, see who just happens to respond and, we're thinking about smoking cessation, like who just happens to. Yeah. So you could have a control group here, and then you could also have, because this is so flexible, this is just like a general framework, you could have control groups here, and you could have them wherever you wanted.
Okay, cool.
Yeah. So this is getting into a little bit of the analysis side of things. So the method for analyzing data from a SMART is called weighted and replicated regression, and typically we use generalized estimating equations with that. So here we have our outcome. So it could be binary, continuous, whatever metric for your outcome, our intercept term, and then we have a coefficient, and then based on which DTR the person was in. So the weights, we use propensity weighting essentially here. So that's the inverse of the total randomization probabilities. So people who are responders only get randomized once, so it would be 1/2 there. And people who are non-responders get randomized twice. And each time they have 2 possibilities, so it's 1/4 there. So then the weights would be the inverse of those. And then for computational purposes, this is just so that we can use like softwares for analyzing the data from these smarts. Records of people, for people who could be part of multiple DTRs, their records are duplicated and one record is assigned to each potential DTR. So if we think about people who were responders to treatment A, they could have been part of the A plus B DTR or the AAC DTR, but we won't really know that because they were responders. So we would duplicate their record and assign one to A plus B, and one to AAC. So then we would have their information basically included in the treatment effect estimations for both DTRs. And then whatever is the optimal DTR is the one that has the highest beta assuming higher is better for the outcome, had the highest beta coefficient. And that would be how you would pick your optimal DTR.
And Holly, is that because the A responders theoretically would have been responders if they had been in either of those other 2?
Yep, exactly. There are a lot of other methods for analyzing data from a smart. So you can use frequentist methods like I just outlined. You can also use Bayesian methods, or you can use AI, machine learning kinds of methods. So Q-learning, tree-based reinforcement learning, and G-estimation are all becoming more common to use with smarts. And a pro of these methods is that you can also identify different optimal DTRs for different subpopulations. So if perhaps older patients should be getting a different kind of treatment sequence than younger patients, these methods would be better at identifying that.
Can you talk a little bit more about that? Because that's a little different then, because that would seem like the subpopulation is based on the response in some ways.
Yeah.
Right, so would you look to see, like on those, would be one of the first things you look at is what makes those groups separate themselves in the first place? Like what are the predictors of the non-response?
Yeah.
Because wouldn't that drive you a little bit to what you do afterwards?
Yeah, potentially. So I've only seen these used more as like secondary exploratory kinds of analyses. So I don't know how you would move forward if you wanted this to be like your primary analyses. But usually they do like the regular frequentist analysis, and then they'll do a little bit of a deeper dive. And with like tree-based reinforcement learning, you basically just feed it all the covariates and baseline information, and then it'll decide what those groups end up being. So like, if you are this age and this, then you should receive this treatment. So it kind of is more data driven rather than you having to decide ahead of time.
You could only do it within the treatment group, because you
Yeah,
would assume
backward.
that
Yes.
that there's homogeneity, right, due to randomization across.
Yeah, but then that doesn't tell
But then
you.
who responds to A
Yeah.
within that group?
Yes, within that group,
Right,
yes.
is where you get to
Yeah.
who comes out as subpop.
Yeah.
Mhm.
Okay, so now I'm gonna go into some examples of smarts in the literature. Good, okay. I'm happy that there's questions because I definitely didn't have enough slides to fill the whole time.
You can fill your time with questions, that would.
Excellent. Okay, so this first study was a pilot smart to improve insulin sensitivity. So the population was people with stage 1 obesity. And so this was a pilot study. Their goals were really not to identify the DTRs. It was more to assess feasibility, look at patient preferences, and then get preliminary estimates. And their outcome, they used insulin sensitivity assessed using the Quantitative Insulin Sensitivity Check Index, or QUICkie. So this is what the design looked like. I wanted to present this one first because it's just pretty much identical to the baseline that I showed. So you have the first randomization to either nutrition counseling or exercise counseling. They defined a responder as a more than 5% increase in QUICkie. So if you respond, you continue your initial counseling. So continue exercise counseling or nutrition counseling. If you do not respond, then you either augment with metformin or you switch to the other counseling method. So retention, so they had relatively good retention, even though the study was, I think, a total of 25 weeks. And then they did also look at patient preference. So over half of the patients preferred nutrition counseling, about a quarter preferred exercise counseling, and then a little under a quarter had no preference in their treatment. And so this table is straight from the original paper, and it looks at adherence. They had pretty good adherence. They looked at, I think the worst one was the nutrition counseling in phase 2 had the lowest adherence, but overall, fairly decent adherence to the various treatments, interventions. This plot I thought was interesting. So this is looking at the change in that outcome quickie. So this first one is from baseline to week 8, and they separate it by responders and non-responders. So it makes sense we're defining responders by this change. So at that 8-week mark when we're evaluating them, it makes sense that responders are not doing as well as non-responders are not doing as well as responders. But then in the second half of this intervention, there was very little change in the responders, but the non-responders actually did improve. So having that secondary treatment intervention for the non-responders actually had a pretty big benefit for that group. And then overall, you can see, it kind of ends up being the average of these 2 bar plots. The responders did pretty well, mainly driven by that initial 8 weeks. And the non-responders kind of did okay, slightly better than no change at all, mainly driven by that secondary intervention.
And then do you know, like, cause they got 2 different options, like Metafor came in as a new.
Yeah, they did do all of the
Yeah.
like extra analyses, and I have the reference, so if we want to take a closer look at it, we can.
Okay.
Interesting is when you think of behavior change, those who change their behavior are the ones that are ready to change their behavior. So if you're a responder by nature, if you're a responder, that means you're kind of probably more open to the change.
Mhm.
And then so it's almost like you're looking at, okay, what about those people who are not ready for it? And if you offer them this other option that continues and maybe gives them more motivation or something else
Yeah.
to hook them in a way that they'll become a responder, so to
Mhm.
speak.
Yeah,
That's
yeah.
interesting.
This seems like this could also imply that if you're a responder by week 8, there's not that much benefit by going all the way out to 25.
Yeah.
Like you can stop at week 8.
Yeah. So I think that they did continue the counseling for the responders, but actually in the next study that we look at, they looked at like if we decrease the dose basically of the intervention among responders. So we'll go to that one. So this is the program for lung cancer screening and tobacco cessation, the Pluto trial. This is one of my pet peeves is when people just like make up acronyms that don't make any sense. So I think it's like PLEO. But
H requires you to come up with that.
yeah,
Like really put the weird.
Even if it doesn't match
Yeah,
up
even if
anything.
it doesn't, see, then you capitalize 2 letters. and-
Yeah, yeah.
the ones where it's like they're picking like middle of the word. I'm like,
Yes.
that doesn't count.
Then it's probably PLUTO.
Yeah,
Yeah.
probably.
Lung and tobacco.
When they write their title, they might even do it capitalized LU, that's how they do
Yeah,
Yep.
yeah.
Or underline, yeah.
it. That is annoying.
So this study was patients who currently smoke cigarettes and were eligible for lung cancer screening. The program that they were looking at was this tobacco longitudinal care program. So it's intensive phone coaching and nicotine replacement therapy. And so the goal was to test different adaptive interventions based on this tobacco longitudinal care that health systems could implement to address smoking in the lung cancer screening setting. So the main goals for this study, the first one was to look at the effect of adding a referral to prescription medication therapy among patients who did not respond to early smoking cessation treatment. So the first aim is about people who were non-responders. And then the second aim is to assess the effect of decreasing the intensity of the TLC program from at least monthly contact to at least quarterly contact among participants who did respond to the treatment. So here they're interested in both what can we do for non-responders and what can we do for responders? Do we actually have to keep continuing this expensive, intensive kind of treatment? So this is their flow chart. It's vertical instead of horizontal compared to all the other ones. So And one thing I also thought was interesting, so they were initially randomized to either 4 weeks of TLC or 8 weeks of TLC, but then they never really addressed that time difference very closely in the paper. They mostly just respond to early treatment non-responders and early treatment responders. So people who respond, they were either randomized to quarterly TLC or to continue the regular TLC. People who didn't respond were randomized to continue the TLC or do the TLC plus the medication therapy. So the results, so this is looking just at early treatment non-responders, so the people who didn't respond. They didn't actually really see any difference between if you got TLC or if you added that medication management. None of those odds ratios were significant. So I think that goes to your point of talking about, if you're not ready to change, you might not be ready to make that change. So even additional interventions among non-responders weren't found to be effective. And then for people who did respond, among early treatment responders, 24 of the 55 participants in quarterly TLC reported 6 months prolonged abstinence compared with 34 of 48 in TLC. So that odds ratio is not significant, but we can see that there is a difference in the response rates here. 43 if you drop down to quarterly versus almost 60% if you stay with it. So here, they do not recommend going down to quarterly TLC. They recommend for people who did respond that you stick with the at least monthly contact TLC. Any other thoughts on those? All right. So now these are extensions to the SMART designs that I think could be most relevant to health behavior research. So the first one is small sample smarts or SN smarts. The framework and design is all the same for these kinds of smarts, but the goal is to identify the single best treatment rather than the DTR. So the idea is to use data from multiple stages and really kind of combine all of that data and share that data between stages so you can get more information from the same number of participants. So this also might be more preferable to a crossover design from the patient perspective because patients can stay on a treatment if it's working for them. This was originally conceived for rare diseases where recruitment can be challenging and there might not be a lot of treatment options. So if you find something that works for your rare disease, you probably don't want to switch off of that. So the main benefits here are more data from the same number of participants, and patients can stay on treatments that work, or they can try other treatments if it's not working for them. So this is the framework from the methods paper for SN Smarts. So randomized to one of 3 treatments. If you respond, you stay on it. If you don't respond, you get randomized to one of the remaining 2 treatments. So here is 3 treatments rather than the 2 that we had been looking at before. And then the analysis method is Bayesian methods because that really facilitates the data sharing between the different stages.
Sorry, can you
Yes.
back on? So, but how do they account for time on that then? Because it would seem like the group that stays on it is on it for quite some time
Yeah.
versus, is there a time factor in this?
So this is assuming that once you are responding, you stay responding to it. So there isn't really a time factor in it. The way that they modeled it was kind of to allow a different effect in the second stage versus the first stage, so they could account for some of that. Or if there was an interaction between the 2 treatments, like A and then B has a different effect than just B alone sort of thing. So the model itself kind of accounted for that, but the design didn't necessarily.
I hope I'm articulating this correctly, but I'm assuming that because it's a small n, that's why we're not just saying just randomized to A, B, and C.
Yes.
Okay, 'cause
Yeah.
I'm like,
You
it makes
can.
it a very complex
Yeah.
I mean, why not just do the 3 and then compare?
Yeah.
If it's the same disease, assuming that there's no interactive, which we know we can't assume, but that's, and so you're saying that they're flipping it so you can actually get more data points for the folks that were originally randomized. And then you can get more Bs, more As, and more Cs that you can.
Exactly.
Okay.
Exactly. So if we had, in a traditional randomized trial, we would just I'm holding up my hand like y'all
Yeah,
can see. You just stop after this first randomization
that's-
here.
Yeah.
And that is way simpler to implement, and so why would you not do it? And it's mostly because you want to get more information from the small number of people that you can get.
And it's an effective way of statistically beefing your N
Yes,
rather than, because you can't physically do it.
yes,
Okay.
yes.
Are you also making an assumption then that if there was no response, it's almost as though they didn't receive the intervention?
That's not necessarily a response, an assumption
Assumption?
here. We still do allow for potential like interaction effects of, even if you don't respond to that first treatment.
But you were saying that this one is used though, so you're trying to find the best.
Yes,
Okay.
yes. But we did try to set up like flexible models to allow for different relationships between the treatments to occur
Yeah.
while still being able to get accurate estimates of if we did this first, what would happen.
Yeah, so it's like almost like you have to do retroactive counterbalance effects, maybe? Like of which treatment came first? I don't know, I may be over complicating it, but
It's much more straightforward innovation sense because you can kind of combine different things.
you can group them.
Yes.
Yeah.
Do you have an example of this, though, like what A, B, and C would be?
I don't hear, but
I
the
think of a,
the original trial was in skin vasculitis. I think it's probably done by now, but I didn't look up to see the final, like if they have a final paper for it. I know there's a protocol paper about it, but it was skin vasculitis, not a behavioral one, so I didn't want
and the
to-
non-response, I think that's the other thing. I think of response as somebody like who just doesn't get the intervention. But you're actually saying non-responses, they're not responding to the intervention.
Yes.
So the outcome has not changed,
Yes, I know what you mean.
right? So you could be getting that medication or that intervention, but you just haven't had a response.
Yeah.
And that's where I guess I'm getting confused by them, because I would think in that next set, those Bs and Cs actually are not Bs and Cs. They are A plus B
Yep.
and C, right?
Yes.
Okay.
So you would stop receiving A at this time point, but then you would then switch to treatment B. And so it wouldn't be that you are at that time receiving both, but
Yeah.
that you have a history of receiving A.
No, but I think it's at the end of the day, if you're saying, well, look, B looks like it works more, but how many of those are B that actually had A and then
Yes.
some residual?
Well, I
Right.
think there's likely the assumption built in that A just didn't work at all.
Right.
That's what I'm
And
saying.
maybe there's some washout before you start B. But
Yeah.
if it hasn't moved, then whether that's accurate or not, that's what it looks like, the assumption,
Yeah,
the underlying
I
assumption.
should have put all the models here because we did allow for an interaction effect, but we also allowed, like, we did in our modeling account for like A and then B happening for these
Yeah.
people. And then separating that out from the like main effect of.
No,
B.
can I just say this, this is maybe more translational to something else, but so often, we'll have an intervention study that doesn't work, right? Or we don't see outcome changes in our population. So now you have this data set
Mhm.
that's considered an intervention study. And you get from the reviewers, you have to always put the control that, and everybody always questions, well, this might be because they had this intervention, even though you say this was shown not to have an effect on this outcome.
Mhm.
So if this is logical here, why isn't that same statistical logic not accepted? Do you know what I'm
For
saying?
you,
Like,
yeah.
it seems like it's the same thing. It'd be
Yeah.
saying that, well, if there's no response, then they had no A.
Yeah, so we aren't assuming that though. We are incorporating that in as an interaction effect.
Are you thinking more of educational interventions?
Well, yeah, or even like, yeah, education, or, I mean, it
Or
could,
behavioral
it could be,
interventions?
I mean, it could be
Yeah.
any of those,
Yeah, 'cause I
right?
think if I come from the field of psychology, so I think if I'm hearing this right, you're saying that their argument is that if they don't make a change, they didn't get the intervention. If there's
That's
no
what-
response.
That's what this is.
But I think this is more like if I have a headache and I take a drug
Yeah,
and my headache is still there.
yes,
That's the no response.
that's the non-response.
Right.
But then they would, but again, I'm trying to say, if the outcome of this is to figure out if A, B, or C is the most effective.
Mhm.
I'm trying to understand how it partials out
But
the,
it's A, B, or C most effective in sequence.
is it in sequence?
smart.
Yeah, I was, this is
A little
different.
bit different, so
Yeah,
this
this
is
is like-
part. So we are trying to find the best initial treatment in the small sample SMART. And then because we allow for interaction effects, we aren't assuming that A has no effect in the non-responders. We are still allowing for some effect of A even in the secondary one,
Yep.
but we're trying to piece it apart with our modeling.
And you can do all that with a small sample, huh?
Yeah, it works really well, actually.
What's small?
Yeah, how small?
I think they looked at, well, it's not super small, like 45 people, and it was working pretty well.
Small.
Yeah.
It-
Um,
It's fascinating because in psychology, we would do studies, we just called it block designs. They weren't clinical trials, but they were very much built this way where you have like this Alzheimer's group got exposed to this visual stimulus, and this visual stimulus. Which one could they see?
Mhm.
And then the healthy older group was, and then so they were all exposed to the same things, but we never called them randomized clinical trials because they weren't clinical trials. They were just which one was the best result.
yeah,
Well, we always called them block designs and then we'd run like analysis of variance by basic stuff,
yeah.
But this is really interesting in terms of that clinical and control piece of it.
Mhm.
Yeah.
Hmm.
Yeah.
I'm not convinced, not
So
that
exciting.
I'm not convinced of this, but I'm like, I'm just frustrated by the fact that this seems to be not questioned.
It probably is.
And yet, you know what I'm saying, like, we have an impact study, that's what I'm talking about, impact study, 360 kids, we have a gazillion of pieces of data on these folks. And we've tried to put stuff in 2 or 3 times now, Rachel was the last one, and they questioned whether, they said, well, even though it didn't work, like, how do we know that their exposure to all of this weight loss stuff didn't have an impact on their physical activity? Okay, the outcomes of physical activity, even though we showed the original study that showed that there was no relationship between these two. And I'm just saying, like, you're told that when they're assigned to a group, that they're forever assigned to that group.
Yeah.
But so you could come up with an argument for why that's not the case?
I'd be curious to see your analysis and like the actual, like the responses that you're getting and,
Yeah,
um,
well, it's just more of a generic, we
Yeah.
got on 2 different papers, just, you have to make sure you're controlling for this group.
yeah. So I think the difference is that we did try to control for that in the analysis methods here. But we were still able to get those treatment effects. And I think that we could apply those same kinds of ideas of like, doing an interaction effect and then probably seeing that the interaction effect is not significant in your case. And like, then
Arguing that, yes.
Yeah,
Ruling
so-
out- Statistically ruling out the interaction effect.
exactly,
Yeah.
exactly.
Or like a covariate type
Yeah,
of thing.
yeah. I think that there are ways that you could account for it and like show,
Yeah.
it didn't make a difference. So I'm curious.
Yeah, I am, yeah, me too.
We should connect.
Yes.
Okay. Done with small sample smarts?
Mhm.
All right.
Cool.
So the next modification is the tailoring function smart. So that tailoring variable, what you define as response, can often be really hard to decide beforehand. So this design allows for a continuous intermediate outcome rather than categorical or binary or, setting some cutoff like the 5% change in quickie or something like that. So then we use that intermediate outcome to map to a probability of staying on the same treatment. So the main benefits here is that the definition of the responder can be determined within the trial. You don't have to decide what a responder is ahead of time. And then because of that, more patients will end up on the optimal sequence. We also compared this to balance randomization where we didn't have any tailoring variable. We just re-randomized everybody and more patients ended up on the optimal treatment sequence in our simulations with that as well. So this is what that would look like. So you would still randomize patients to your initial treatment, and then we would measure some continuous variable y1, and then we would have a function of that y1 being that randomization probability. And then 1 minus that function to be your re-randomization probability if you're not sort of equivalent to a non-responder, you didn't do as well. And so when you're choosing a tailoring function, more favorable outcomes should map to values that are closer to 1. So you have a higher probability of staying on that same treatment if you are doing well. The analysis methods, so we can't use that weighted and replicated GEE that I discussed because that is based on having that tailoring variable. So you have to use Q-learning or tree-based reinforcement learning. This one is a paper that I did, so I'm much more familiar with this than the small n one. But we found that both those methods worked really well, and we were able to get good estimates of both what the cutoff should be in determining what a response was and in identifying our optimal DTR.
So can you bring back the last slide? So you're saying it's the FY1?
Yep.
Is what you're,
That's the tailoring function.
that's the tailoring function?
Yep.
When you say that, does that mean you're just literally randomly changing it, or how are you determining that?
So what we did in our simple model was we assumed that Y1 kind of varied from 0 to 100.
Okay,
And so then we just did Y1 divided by 100. That was your probability of staying on the same treatment.
okay.
We assumed higher was better. So if you scored 100, that was like, you did great on that. So you really want to stay on that same treatment. If you scored 0, you don't want to stay on that. So that's how we tested it. But you can do different, like you can get really funky kinds of equations as well. Like if you want to have more people stay on that same treatment or you want to have more people switch on the same treatment, you can do the different adjustments to that formula as well.
What would be the reason you would adjust that formula? I mean, because I love that easy assumption, right? 100% it's doing great, 0% it's not doing well, and then anything closer to 0 is like if you have a threshold cutoff, say
Yeah.
50%, that just sits well with my psychometric background.
Yeah.
But so what would be the reason for modifying that?
So if you were expecting your outcome or your Y1 to be like really skewed or something like that, where like most people are going to be between 0 and 20, but it could go up to 100,
Yeah.
you would not want it to be that because then
Right.
almost everyone would still be switching.
Previous knowledge of
Yeah,
data.
yeah.
Okay, yeah.
If you have no previous knowledge, we showed that even if you do a really bad job of picking a tailoring function, it'll still work really well and you can still get good estimates. But the better you can do with your initial pick of that tailoring function is better for the patients who are actually on the trial. But the results, you should be able to still get good results from the trial. It's just more like of the people who are on it, they might end up on the wrong treatment path.
Right.
Or
I
non-optimal.
just had an overall question, like, how do you know, like, is this like a model fit kind of thing, or is it a probability? Like, when you're looking for that, saying, okay, you said like, we got that estimate, we know where that is. Is it like a model fit? Or what is the statistic that you're using to determine where that FY1 is? Like, how do, you said we got that, you said something like, we knew what the best estimate was.
Oh, we did simulations for this. So we basically set all the different parameters. So we had like treatment effect for A and treatment effect for B. And then we simulated, responses with some distribution here. And then we tested different kinds of functions. So one was just linear, one I think I did like a squared, and then one was a square root function for it. And we tested those under a bunch of different scenarios where like the mean was way high for A and B, the mean was way
What
low.
were you using then to compare all of those to determine which one was the best one to use?
So
Is it-
because we knew everything, we could actually compute what the actual like switch point was supposed to be for non-responders and responders. So then we just looked at how close that estimate was from our model to the known value. So basically the bias in that estimate.
Okay.
And then we also looked at assuming that then we also looked at if we applied the DTR that the model found to be optimal in a new population, how did those people do compared to what would be actually the true optimal DTR?
So that like you validated it using actual.
That would make sense, yeah.
It was all simulation
Oh.
based,
Oh.
unfortunately, because this type of study has never actually been done before. So we don't have any real data to play with, but we did do like assuming the same treatment effects in this new population, here's what would happen if we did apply the DTR that we identified.
So it's a.
And we're thinking.
It works well as a simulation.
Yeah, I was gonna say, like, it's.
But even what we did also mess with, like, we did like, okay,
You
so
said
let's
mess with
say, yeah, let's find out what's, you know,
What
if it works
happens if we
really
do
well
this?
here, let's
Yeah.
break it. So we
Okay,
did
yeah.
test like.
Yeah.
15 different scenarios with.
So many scenarios.
5,000 or,
Yeah.
I take it this is sort of a machine learning situation then, is that correct? Or just,
Some of it was machine learning. The tree-based reinforcement learning was machine learning. The Q learning we did with just linear models. And we did assume linear relationships, so it worked out well.
oh,
Are you ready for the next?
Sure.
Yeah.
Okay. So this next one is partially randomized patient preference smarts. So this allows patients to choose a treatment at baseline and if they don't respond to their initial treatment. The idea is to use information from all patients, including those that were not necessarily randomized, to get those estimates of the treatment effects. So the benefits here, patient-centered, patients, you know, love to pick their own treatments, they want to pick their own treatments. They found minimal bias doing this and it uses all the available data. A lot of times where you have patient preferences, it will only use the people who were randomized who didn't have a preference, and that's a loss of a lot of information. So this design gets a little bit messy because there are so many different places where patients can choose. So the idea is you get their initial preference. So do they have a preference of what treatment they want initially? If they don't have a preference, then you randomize them. If they do, then you give them which treatment they prefer. And then if they don't respond to their treatment, even if they were initially randomized, they can still then choose their second stage treatment. So if you didn't care in the first place and you were randomized to A, but you didn't respond to A, and now you do have a preference, you're like, that didn't work at all, and here's what I would like to do, then you can still get that patient preference here. If you still don't have a preference, then you'll get randomized again. And so the idea is that you can combine all of this different information to be able to get the optimal DTR, assuming randomization, which is the ideal, is what you want, is like assuming an unbiased treatment selection process. This is a relatively new paper, so I think it's 2024, but it might have been 2025. And this was my grad school mentor was doing this, so.
So does this then, would it assume that if it's like treatment preference, yes or no, that that's kind of you know, more or less 50-50? Because what if some, like, just by the nature of the treatment, a lot of people want to go in one direction?
They do assume that you have people in all of the treatment pathways, but they don't make the assumption that it has to be 50-50.
Or an equal.
Yeah, it doesn't have to be equal, but you do have to have people who go down each of these different routes, basically, in order to get the best estimation.
and I think I heard you say something about this being randomized still. But I think I'm curious about the non-randomization effect of a self-selected group.
Yeah.
So like if I want a certain treatment, that means I'm a certain kind of person that makes me different from the group that doesn't want the treatment that I want. And that's why we have the control groups to start with for the clinical trials.
Yeah.
Is that addressed here? Am I?
It isn't addressed very well in the paper, I'll be honest with
Okay.
you. Like if there is some inherent difference here, but they did look at multiple different ways of analyzing the data. So they used frequentist methods and Bayesian methods. And I think the Bayesian methods end up being a little bit more flexible for allowing some of that, like you being a
So you can
different.
account for it
Yeah,
statistically.
yeah.
Yeah.
But they do also have, so the 1 and the 0 on these pathways denote if you were randomized or if you chose that pathway. And so they do estimate them all kind of separately
Okay.
too.
Yeah.
Yeah, so they kind of pull out that piece.
The fact that they have two different times do they know from the beginning, like, do they know from the beginning that they're also going to have another chance to have a preference? That would, I would think psychologically would make a difference.
I
Um,
would assume that so, just
But they
with
tell-
my experience of the IRPs with like
You
the
gotta tell people,
I
Yeah,
have
yeah.
one right now, it's not quite fully this, but they get randomized first and then they get treatment. Selection preference.
okay,
If it doesn't work after a certain.
so they get
period of
randomized
time.
first though to.
They're randomized first, so it's like a traditional and
Yeah.
then they get
So
at
some
the
of them get a
tailoring
preference.
point. They get to do a preference.
And are you?
And yes, they do know they
Yeah.
can do that because you have to outline that.
Right.
And that was added because it was a patient-centered study, and that is what they said they needed. Otherwise, people
Yeah.
would not say yes to participate
Gotcha.
in said trial.
I would
Um,
love to try to do this with the groceries, the medically tailored groceries, because we have it either being delivered or picked up or versus getting money. I mean, it's, we get people all the time that say, I just don't, I don't want to cook. We just talked about this today. And, you're like, you're giving them no other option,
Yeah.
right? And then they're not even a good control then because they're in the treatment group and they're telling you right off the bat that they're not going to do anything.
Yeah, well,
Right.
or it could be a different one of these where when that happens and they're like, no, this isn't
Yeah.
working, then you add on.
Well,
the
exactly. That's what-
coaching, you know, like.
Well, you could, that's
so
true.
it-
That is
It could
true.
be the additive impact because maybe they just need more resources.
Yeah, like
Yes.
the other trial where
Yeah.
they like didn't respond.
Yes,
and
and you
then
do
they
it.
did.
Yeah.
Yeah. Which it seems like, just with these kinds of interventions that we all do, they typically involve like multi-component interventions, but like,
Yeah.
everybody's different and we assume that everybody needs all the components, but maybe some people have the exercise already handled and you don't have to
Yeah.
spend money on that
Mhm.
component. You only need to spend money on the diet,
Yeah.
you know what I mean? So
Yeah.
it seems like, like we were talking about, we want third-party payers to pay for stuff. Like if we designed it like this, you could say this type of person, with these characteristics.
Yeah,
these-
selected,
Yeah,
yes.
so you could like only pay for what
Mm.
needed to be paid for.
I'm also curious about, I think going back to like sort of the original time that I, learned about controlled trials and or experimentation versus, correlation or the idea, just the idea of a placebo in general of how,
Mhm.
like even in the first one, I'm thinking, okay, the responders are the ones that believe it's going to work. And there's the placebo effect, right? And then if you get your preference, you believe it's gonna work, and that's your placebo effect. And then by not having a control group, you're no longer, and I'm not saying the placebo effect is not important, because honestly, how much of successful treatment is the placebo effect, right? And if we can lean into that and say, well, that's okay, if they believe it and it's working, then great. So I'm really curious about, that part of it and behaviorally, how these effects might be either capturing that in a positive way, which we could kind of spin it that like, yes, that is part of the success of something, is that someone believes in it and it works.
Yeah.
But it's very curious, that they kind of, because to me, that would make those two groups different. Like
Yeah.
someone who has a preference obviously has hope or belief that something might work. Someone who doesn't is probably just like, kind of like hypnotism, if you're more inclined to be, not that, any kind of
Yeah.
mental belief state or, with smoking cessation and those kinds of things.
Or you could just have a bias against the other treatment. It's not that you so much believe in treatment A, you're like,
You just
no,
don't want-
treatment
yeah.
B sounds awful.
Yeah.
So it
Yeah.
could be.
Or you're not willing for some of the counteractions or like the, what you might have to do for treatment B.
Right.
Yeah.
Or
This isn't really like a
C,
drug.
that it doesn't fit within your like context of, like you said, even like the cooking one, like,
Yeah.
it's not that you don't think that's not gonna work, but you're like,
You don't.
I live in a home and I don't have
Exactly.
a stove that
Which
works.
is why the preference should be taken into account.
So,
Right.
but
Right,
it's
it's like
not that,
availability
Yeah.
for change though, is I guess what I'm looking at, like the availability to allow the change to happen, whether you believe it's going to happen or that you're willing to try it. Do you know what I mean?
Oftentimes in these sorts of trials, there is no pure control.
Exactly.
Right, so
More
something is
more
getting,
so that-
right, there's something, if you have a problem, there is some sort of of active. Does this paper or do any other papers related to this method offer examples of like outcomes or interventions that might work well for this design?
Oh, yeah.
That's what I'm trying to.
Yeah, yeah,
figure
I
out.
did
Right, they were referencing, like substance use was one of their example cases, but I will have to go back to the paper and see, because I don't quite remember if they did any concrete examples.
It would be interesting to sort of do the extension of, right, now that we've got the statistical method underneath, what are some exemplar?
Yeah,
right,
examples.
some outcomes and some intervention treatments, whatever,
Yeah.
that might be ideal. Because I think it also matters in what makes sense and how you approach certain outcomes with certain interventions, right? That might be informed by like a population method. So like thinking about tobacco cessation, like maybe first you offer the quit line, and then if that doesn't work, then you move on to spray. Or, right, do you give this preference of what makes sense in this as far
Yes.
as how people would experience and how you might realistically move them along? Because it seems like it's nice to know what works, but it may also be sort of what works for whom.
Yeah, that's.
Yeah.
exactly
That's
right.
right.
And when,
yeah,
and when is it?
yeah.
Yeah.
The
It
treat
seems
and
to
the
mimic
state.
more real world.
Yeah,
I was just gonna say,
Life happens and
No one size fits all.
Well, and also not applying the placebo effect. I think that's always been, like in community trials, none of us can do that anymore.
Right,
You can't not give people something.
Exactly.
So now you
Yeah.
are looking at the differences between A, B, and C, and it's not really clear which one might be better than the other.
Yeah.
So to me, this really is an applicable model
Yeah.
more in that case than, but I guess still the question is, like, I like the notion of preference, just
Yeah.
period.
Yeah.
Just having that as a notion. So what if the person, because I think here, they may think it may work.
Mhm.
Wouldn't it be it's the second path that would be the most telling.
Yeah.
Yeah.
Because what they do with that preference, because that assumption would, like you're saying,
Yeah.
Sarah, would be is that if they said,
just
yeah,
go
A
boom, boom,
works,
boom,
you give
boom.
me
Yeah.
A, they'd be the best
Right,
one.
right.
That may not be the
Yeah,
case.
that would be.
Yeah, so it'd be interesting to compare, like, if you chose A and you responded versus, and like, the response rate for if you just got
Yeah.
random.
Yes, yeah.
Yeah.
And then I wonder, so in this, if you choose either your choose or your randomize, whichever one.
Yeah.
And you go through and you're like, yep, A works for me. I'm a responder. But when we think about behavioral change, oftentimes folks just stop doing the
Yeah.
intervention or adhering to said intervention
Mhm.
because it has worked. Is there,
Mm.
do they have to continue with adherence to the intervention for the time frame analysis with the ones who are non-responders? Or do you compare at the time where they have said, yes, I'm a responder? Because the drop off
Yeah,
in adherence is,
so in this, they assume that once you're a responder, you're always a responder.
Yeah, which we know that.
It is not the case.
Well, that might be the case in a drug.
That's very
or
true,
in
yeah.
a treatment, right? Did this
Yeah, no,
antibiotic
yeah,
cure
yeah.
this infection?
Yeah,
But behavior's just a bit more complex.
yeah.
Isn't it though?
And so all of it, like, the methods developments for these smarts is very much like in the biostatistics kind of world, and there's very few of us who communicate with like behavior researcher,
Yeah.
So I'm also very interested in all of like what you're saying, because as a statistician, I would not have thought about all of these things too.
When I make the translation of drugs, what I think about is oftentimes drugs, we know the exact mechanistic pathway that the drug is acting on. And oftentimes in behavioral stuff, right, we don't necessarily know which behavioral mechanistic pathway we're affecting, or if that's the right one that's going to have the pathophysiological response that we need, for if there is a biological outcome. And there's just complexity in the interplay, right? It's not a one-to-one of like this behavioral intervention gets this outcome in the same way that amoxicillin gets you, right,
Yeah.
infection-free. Right, and if it's the complexity of that mechanistic pathway that is not a one-to-one comparison of treatment to outcome, and how to accommodate that, account for that. in
Yeah.
models.
just to tag on to that, it's also like the interaction between, we don't know what unmeasured thing, like, them not having a stove, like, there's all of these other things in their lives that can interplay with the treatment in a behavioral study that like we have no control over. And so like with that person in path A or the treatment A, like it seems like
Like the
people-
self-selection though, in some ways would somewhat balance that out.
Yeah.
Right, because it would work through their preference if they know I don't have a stove,
Yeah.
Yeah.
right? Or, so that,
But what if your what if your environment or like what if the things around you change somewhere in this
Yes.
process of
Yeah.
yes, no, then you don't know if how how the outcome variable is changing is due to a change in their environment
true too.
or due to a change in the treatment.
Yeah.
You know what
They
I mean?
got
Might
us
measure
there.
more
Yeah,
things and use
exactly.
patient-centered outcomes that are matter.
Yeah.
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 Or I say patient-centered because I do that, but I mean, it's the participant-centered outcome.
Yeah.
Find out what are these other factors that need to also be measured at the same time as your main outcome, so that you can then
There's so
calculate.
many things.
Yeah, well, I mean, they're confounds, right? These
Yeah.
are all the confounds we can.
That's
use
right.
No, we don't use that word anymore.
Sorry.
But also it's context, right? It's not
That
just
is
you're
context,
controlling
yes.
for this, but
Right,
oftentimes it's an important contextual variable that
Yes, yeah.
inflame. And I would say that we're finding that's also more true now, even with drugs, right? That there's
Yes.
environmental interactions that
Right.
determine whether or not
Genetic and everything else.
epigenetic, right?
Yeah.
That drugs work or don't. But there's still a clear, right? The pathway is still a bit more simplistic, right?
Yeah.
Yeah.
We still
So.
come back to I keep saying, like, we say, oh yeah, you have to control for these things, but your sample size has to be mammoth. When in
Yeah.
traditional methods that we're talking about.
Yeah.
And
So,
so what's the sample size for something like this, Holly?
I don't think we've explored.
Okay.
Next on the burn.
I would assume large,
Large.
especially if you're expecting a lot of people to have a preference. So like if you do have a large proportion going this direction,
Mhm.
I would imagine it's gotta be pretty big, but I didn't even look at what they, because again, this is all simulation based, so I didn't even look at what size they simulated. Very quickly, I wanted to talk about some smart developments that I'm interested in doing, because one of them is exactly what we talked about, smarts that allow for relapse. So like what treatments for a person who responds and then does not respond, but this does then require more than 2 stages, because you have to have that response, not response, and then another treatment stage after that. So it would have to be longer and more intensive, especially on the researcher side. So just thinking through all of that. Smarts to move through a progression, like stages of change. We talked about this, yeah. That's really got my brain going. So like if you are thinking that you want to get this person to some ultimate change and move them through those stages of change, is it okay if they jump the stage, if they regress the stage? How do you get the people to that final outcome? And then I have a student who's working on adaptive tailoring function smarts. So rather than just using that patient's outcome for that intermediate randomization probability, thinking about incorporating all that historic data too. So what have other people responded to well, and using that information.
In general, I was gonna ask you that, because Shirley Moore used to always talk about adaptive designs and in clinical trials. Is that what smart designs are? I mean, how does it, because it doesn't look that different. Like she would do something like if they were not responding to an aspect of the intervention, right? It wasn't so much the outcome changed,
Mhm.
but like if there was something in the uptake that was varying, then there was another intensive piece to it. Is that, I mean, that is the same thing, correct?
Yeah.
All right. I'd love to, I mean, there's obviously a lot more, because she said she's had to fight it a lot when she was like suggesting it in the early, probably 15 years ago now.
Mhm.
She put it in our impact study, and there were a lot of people that were like, well, then you've just ruined the design. If you changed
Yeah.
anything, right?
Yeah.
So it's like, this has come a long way then, if there's an acceptance of this. I just wonder, where are the two worlds when you try to put one of our studies into these designs and go to NIH with them?
Yeah.
What would they?
Well, right now they would say nothing.
Yeah.
That's true. That is true.
Yeah, adaptive designs really have come a
That's
long
true.
way, especially like the statistics for dealing with that, because And I mean, also just because computational power has increased too, we can do more complex statistics too, so. Yeah, definitely a lot has changed, and I think it's gonna continue to change, and, because it has to.
I have a question about the one with the intermediate outcome. Again, I could be conflating all of these things together in my brain, but like, what, can you give an example? Like, I'm just thinking about, in terms of, obviously I think about diet a lot. So like, normally we would consider diet an immediate outcome, which is very hard to measure. And then like, maybe a change in blood pressure or change in cholesterol or whatever as like a long-term outcome. And so if with that design that you were talking about, we would be tailoring like changes to the treatment based on their reported dietary intake.
Yeah.
Right?
Yeah,
It should be the first response.
Is that,
Yeah.
that's
Yeah.
the first response.
Because can I suggest, that was the same thing I was thinking early on about this new study, is that we have food insecurity as sort of the reason we're doing this.
Mhm.
Well, if you study them, 8 months or 8 weeks, depends how far you'd go in before the delivery. But if we have not changed their food insecurity,
Yeah,
it seems like at a bare minimum, we ought to be changing the amount of food they're getting or something,
yeah.
right? Other
I
than just
actually
letting them.
saw a protocol for food insecure pregnant women about medically tailored groceries. I know, that was a smart design, and I was like,
Where did you see this?
it was just a protocol, so it's not like they've
Yeah, well,
done
they
it
might be in the
yet.
middle of the study. Was it in the clinical trial that?
I believe so. I'll find it because I was like, oh, Elaine would like to see that. I
Yes.
think.
Because I do feel like
Yeah.
now that we've looked at the results from the pilot, if you've got 30, you're only really impacting like 35% of their food insecurity.
Mm.
Well, if you're only impacting that, what chances do you have of affecting
Yeah.
their pregnancy outcomes,
Right.
right?
Yeah.
Do you know offhand, just pivoting a little bit, but you
Sure,
mentioned you
yeah.
have all of this impact data. Are there, is there an appetite, which is a huge question right now in this federal environment, for secondary analysis to apply these new methods to existing data sets like this, where you might be able to try to use these designs in some sort of way, right? Where these large trials with a lot of data, could be, right, sort of
Yeah, I would love if
repurposed.
somebody would use them.
Yeah, so the design itself, once your study's done, you can't really change the design, but there are a lot of methods to develop DTRs from observational data, like the Q learning and the tree-based reinforcement learning. Those don't have to be randomized trials. Those can be just sequential treatment data that you have.
Yeah.
But yeah, there's a lot of,
Like, could you potentially go into like I was at the Cleveland Clinic for a time and there's so much access to medical records.
Yep.
Just like massive amounts of medical records.
Yep.
And could this be something that could then be retroactively applied to like observationally, obviously, but to those branches of potential treatment from a historic perspective?
yes, that's actually what one of my students is gonna do with Cleveland Clinic multiple sclerosis data.
Wow.
Yeah.
Okay. I was over in that building, Mellon.
Yeah.
I was Catherine's.
Yep.
That's amazing.
Yeah.
I just got the goosebumps. I mean, there's just so much data now.
I
you
know. Yeah.
Well, we're 5 minutes over time. This has been
it's
over.
not really.
Thank you.
Continue the conversation.
I think this also kind of leans into us having more methods, paid seminars
Oh, yeah.
with people that can actually talk to us, because, we really haven't had this ability in a long time to talk